on this week's video. On this week's video, we're continuing with our ongoing series entitled The Precedential Cases, the Medical Legal Game Changers. And in today's session, we're in session 4 of this new program. And I have a fascinating session for you today that I'm sure is going to be very helpful to you, perhaps even in your very next evaluation. And before we get started on the topic of today's discussion, let's just take a brief review as to the topics we've discussed so far in this series. We began this series talking about perhaps what is probably the most critical topic that you need to be aware of as a qualified medical evaluator, and it has to do with qualifying your opinions and conclusions. Any opinion and conclusion in your report, in fact, all of the opinions and conclusions that you offer in your report, they all need to qualify as substantial medical evidence if you want to be considered an actual player in this game. Qualifying your opinions and conclusions as substantial medical evidence will set you apart and set you into the class of qualified medical evaluators known as the big dogs. Now the little dogs, the little dog qualified medical evaluators, offer opinions and conclusions just like the big dogs. But the little dogs offer what are known as conclusory opinions. And conclusory opinions are opinions that contain no support. They're opinions that are devoid of supporting reasons, supporting facts, supporting data, supporting medical decision making that solidifies and qualifies the opinion as what's referred to as a substantial opinion. And anyone can offer conclusory opinions. It takes no skill, no talent, no particular insight into the case to offer conclusory opinions. On the other hand, if you want to be considered one of the top shelf qualified medical evaluators, then you can begin your quest to become a top shelf evaluator by qualifying each and every opinion that you offer in your report as a substantial opinion. And we talked about exactly how to do that in our discussion regarding the Escobedo case. So I encourage you to take the time and the medical decision heavy thought-making process necessary each time you offer an opinion and a conclusion in your report to set out to the reader of the report, set out to the reader your reasonings and your explanation as to how and why you arrived at that particular opinion and conclusion. And this will really tremendously enhance your reputation as a competent, qualified medical evaluator. And then in our next session, we talked about the Almarez and Guzman line of cases. And second to Escobedo, the Almarez and Guzman line of cases have probably been the most influential and impactful of all the cases that relate directly to the work that we do as qualified medical evaluators, because the Almarez and Guzman line of cases basically blew the lid off of the constraints that were imposed by Senate Bill 899 when it was passed in 2004. Senate Bill 899 had as its intent, its legislative intent, the reason Senate Bill 899 was passed was to help constrain what were referred to as skyrocketing costs in California workers' compensation. And Senate Bill 899 had many new measures and many new strategies with which to contain and constrain costs. But the Almarez and Guzman line of cases basically blew the lid off of Senate Bill 899 and unlimited the permanent impairment ratings that we as qualified medical evaluators had previously been limited by and constrained by the AMA Guides 5th edition. So Almarez and Guzman really blew it open. And in our second session, we talked about how to provide permanent impairment ratings, alternate permanent impairment ratings under Almarez and Guzman. And we combined some of the philosophy of the Escobedo case, and we talked about how to qualify your alternative impairment rating as substantial medical evidence. So that was a tremendously powerful session. And that's a session that you can refer to and refer back to throughout your career as a qualified medical evaluator. In our third session, we built upon the Almarez and Guzman line of cases by talking about the kite case. And the kite case sort of piggybacks on the Almarez and Guzman cases, because without the Almarez and Guzman cases, the kite case would never have any teeth or would never have any traction. And the kite case provided another mechanism for qualified medical evaluators to unlimit the permanent impairment ratings that are otherwise quite limited by the conservative application of the AMA guides. And the kite case is what allows for huge permanent impairment ratings by eliminating the negative, constraining, and compressive effect of the combined values chart. Now, the combined values chart on page 604 has a compressive effect on combining multiple impairments, such that when you combine 2, 3, 4, 5, 6, 7, and 8, 9 different impairments, because of the compressive effect of the combined values chart, it becomes increasingly difficult to approach a 100% impairment rating. The line, the curve of permanent impairment ratings becomes asymptotic to the 100% line, and it can approach the 100% line but becomes asymptotic and never really actually touches the 100% permanent impairment rating because of the compressive effect of the combined values chart. Well, if you eliminate the necessity of combining impairments and you simply add impairments without the compressive effect of the combined values chart, it quite easily becomes quite easy to provide for permanent impairment ratings that easily exceed 100% impairment, if you can imagine that. So the kite case and the procedure espoused by the kite case, which is adding versus combining impairments, tremendously increased the permanent impairment ratings that qualified medical evaluators are able to provide in those cases where it makes more sense to add impairments versus combine impairments. So that brings us to today's session, and today I want to talk to you about the Cannon case. Now, the Cannon case I've discussed in other continuing education programs, and the Cannon case is now getting to be a little bit of an older case. It was a 2008 date of injury, but the case itself didn't get resolved until 2011, and this is being recorded here in 2019. So this case is a little bit of an older case, but the principles espoused in the Cannon case are timeless and relate to each and every one of the evaluations that you're involved in that involve permanent impairment ratings. So the Cannon case, the Cannon case to me is a mind-blowing case because it involves a situation where the medical evaluator, and this involved an agreed medical evaluator, the agreed medical evaluator provided for a permanent impairment rating by analogy under Almarez and Guzman. Okay, so this case would not be possible if we first didn't have the Almarez and Guzman line of cases. But he provided for a permanent impairment rating by analogy under Almarez and Guzman. And the analogy is so remote. The analogy is so distant. The analogy is so weak. In my opinion, the analogy is so weak as to be, to me, incredulous. And what's even more incredulous about it is that the agreed medical evaluator's analogy, his analogous impairment, was upheld by the appeals board. So the Cannon case, and when we get into it, you're just going to be amazed. The Cannon case sets the precedent for providing permanent impairment ratings by analogy to activities of daily living. And by analogy to conditions that create similar limitations in activities of daily living, even if the conditions that cause the same limitations are extremely dissimilar or in no way related. And I don't know if I stated that clearly, but it'll become more clear as we review the Cannon case, which in my opinion is just going to be mind-blowing for you. Okay? So in our next session, we're going to talk about the Mendoza-Garibay case, which is another application of Almarez and Guzman, and it includes some other surprise liberal interpretations of some codes and statutes. So that's another permanent impairment case. And then we're going to finish the program in session 6 with an apportionment precedential case. Also not a new case, but the Benson case teaches us some important principles about apportionment, especially in those cases where the examinee is involved in 2 or more industrial injuries. And those 2 or more industrial injuries become permanent and stationary at the same time, as qualified medical evaluators were required to provide an apportionment determination as to the percentage of permanent impairment due to each of those industrial injuries. Well, in certain circumstances, it becomes very difficult to discern or to determine how much impairment is due to injury A, how much impairment is due to injury B, and the Benson case gives us some instruction as to exactly how to do that. Okay, so I have a fascinating session for you today regarding the Cannon case, and so with no further ado, let's begin. Okay, so let's begin. We're talking about the Cannon case, and I believe it was Cannon versus City of Sacramento. So Cannon was a 37-year-old police officer who, in the course of his normal work duties as a police officer, suffered unilateral plantar fasciitis. Now, I wonder if you've ever had plantar fasciitis. If you've had plantar fasciitis, you're going to be able to relate to this case. Now, I myself have had plantar fasciitis probably 5 times. Probably 3 times in one foot and 2 times in another foot. And I remember some of the causes of those episodes of plantar fasciitis very clearly. In other cases or at other instances, the plantar fasciitis came about seemingly with no known cause. So plantar fasciitis can sort of be an idiopathic condition, or it can be caused by even a sudden single event, as happened with me on a couple of occasions. So if you've had plantar fasciitis, you're going to be able to relate to this case. So he was 37 years old, and he received medical treatment for his plantar fasciitis. And if you've had plantar fasciitis, I want you to think about the medical treatment that you had. Treatment for plantar fasciitis is generally a conservative type of treatment. It may involve the use of orthotics. May involve the use of some stretching techniques for the plantar fascia. It may involve some icing techniques, some taping procedures to support the plantar fascia. And treatment is generally a conservative type of treatment until the condition equilibrates itself and slowly resolves. So that injury was in 2008, and then Mr. Cannon was evaluated by an agreed medical evaluator in 2010, and the agreed medical evaluator found a normal physical examination. So I want you to think about what would be the physical examination procedures for the assessment of plantar fasciitis. Under the AMA guides, we would probably check the ankle for range of motion, and Mr. Cannon had normal range of motion. We would check the foot for peripheral nerve function, and Mr. Cannon had preserved and intact function of the peripheral nerves that innervate the foot. The vascular examination was normal. There was no ankylosis. There was no atrophy of the calf or the quadricep on the involved side. And so the physical examination was normal. Okay, let me emphasize, the examination was normal. Now, how many times in the course of your examination of injured workers does your examination come out normal? Many times we're left with a normal physical examination in the context of an examinee who presents with subjective complaints. And Cannon had subjective complaints of some pain and discomfort in his foot, especially with prolonged running. So he was a police officer, And on occasion, there are requirements that he engage in prolonged running, for example, to apprehend a suspect or something like that. Other than that, for standing and walking and routine work activities and activities of daily living, Cannon had no limitations to activities of daily living. It was only during prolonged running that he was even reminded of his plantar fasciitis. And running was a very less than occasional type of activity that he was engaged in. So basically, Mr. Cannon had a resolved plantar fasciitis. And I've had plantar fasciitis about 5 times. And even though it's a pain in the foot, while the condition is active, once it equilibrates and becomes less and less symptomatic, it basically recovers to a pre-injury condition. Well, despite a recovery to a near pre-injury condition, despite some scant subjective complaints of some pain during running, the agreed medical evaluator provided for 7% whole person impairment. 7%. Now, 7% is a huge permanent impairment rating. And I'm going to give you some idea as to how 7% in this case of plantar fasciitis compares with other lower extremity conditions that amount to 7% whole person impairment. So let's just compare this 7% whole person impairment with other lower extremity conditions. Now, when it comes to examining or assessing an examinee for the presence or absence of lower extremity impairments, Table 17.1 of the AMA guides us in our physical examination procedures. So Table 17.1 describes 19 different types of impairments that we need to assess the examinee for. So there are anatomic impairments, there are functional impairments, and there are diagnosis-based impairments. And you need to assess every lower extremity case for every one of these impairments. So you should set up your physical examination template to assess for each one of these impairments. So let's think about how some of these impairments could or could not be involved in a case that involves plantar fasciitis. Well, plantar fasciitis is not going to cause a limb length discrepancy, so the examinee will not qualify for permanent impairment due to limb length discrepancy. It will not qualify for impairment due to atrophy, due to ankylosis. There's no amputation involved. There's no arthritis of joints in a post-plantar fasciitis case. There's no peripheral nerve injury. The vascular examination is going to be normal in a case of plantar fasciitis. And the examinee hopefully will not present with chronic regional pain syndrome. Typically, the ankle range of motion in plantar fasciitis is normal. There will be no particular gait derangement. And we're not sure in this case if the agreed medical evaluator actually did a gait evaluation, but he did not describe an actual derangement of gait. Strength to manual muscle testing in ankle dorsiflexion, plantar flexion, inversion, and eversion will likely be normal. There's no impairment due to fracture. There's no ligament injury. It doesn't involve the knee or meniscectomy. And so typically with a case of plantar fasciitis, there will be no associated impairment that's described under the strict application of the AMA guides. But in the Cannon case, the agreed medical evaluator created an analogy to one of these impairments and provided for a permanent impairment rating by analogy. In this case, he used an analogy to a gait derangement in an examinee who had no actual gait derangement. Okay? So, and he provided for 7% whole person impairment by analogy to a condition that Mr. Cannon did not have. So this is a huge permanent impairment rating for a condition that the examinee did not have. So let's compare this 7% permanent impairment rating to some other lower extremity impairments. Okay, so let's compare the 7% whole person impairment by analogy to gait derangement with some other impairments for lower extremity conditions that also provide about a 7% impairment rating. So here is table 17.8 related to lower extremity muscle weakness. And let's just go through the chart and look at some impairments that cause about a 7% impairment rating. And notice here that a grade 4 strength loss impairment. Grade 4, you'll remember, is active movement against gravity with some resistance, not full resistance, but some resistance. For a grade 4 strength loss at the hip and hip extension, that provides for a 7% whole person impairment rating. Now, if an examinee is weak in hip extension, I want you to imagine how that might impact activities of daily living. This is an examinee who's going to have trouble propelling his body against gravity through extension at the hip. So this is going to be an examinee who's going to have difficulty walking up hills, walking up stairs. This is an examinee who may have a gait derangement in the form of a shortened stance phase as the hip fails to go into full extension. And so this is an examinee who is going to have actual limitations to activities of daily living. Now notice here a 7% impairment rating is also associated with grade 3 strength of the knee in both knee flexion and knee extension. Now recall a grade 3 strength rating involves active movement against gravity only with no resistance. So this is an examinee who's not going to be able to bear weight due to knee weakness. They're not going to be able to extend their knee against anything more than gravity. This is a knee that's going to give way under the weight of the examinee. So this is an examinee who's going to have a significant gait disturbance due to grade 3 strength at the knee, and yet this qualifies for 7% whole person impairment rating. Okay? Similarly, grade 4 strength at the ankle in ankle plantar flexion, that's going to describe an examinee who's going to have difficulty raising up on his toes, flexing the ankle against resistance, such as during the toe-off phase of gait. During the late stance phase, during the toe-off portion, that late stance phase, this is an examinee who's going to have a shortened stance phase and a significant gait derangement due to weakness of ankle plantar flexion. So in each of these cases of weakness, the examinee is going to have an actual derangement of gait associated with these weaknesses, and the derangement of gait in each case qualifies for about 7% whole person impairment. And interestingly, Mr. Cannon had normal strength at the hip, normal strength at the knee, normal strength at the ankle, and no actual disturbance of gait, and yet the agreed medical evaluator provided for similar 7% whole person impairment rating by analogy. Okay? Let's look at some more lower extremity permanent impairments. Okay, so just as an example, here we have table 17-6, which provides for permanent impairment ratings due to atrophy of the lower extremity. So in section A, we have atrophy ratings for atrophy of the thigh. Section B, we have atrophy ratings for atrophy of the calf. And notice here that nowhere do the atrophy ratings even approach 7% whole person. For neither the thigh or the calf, neither of those areas provide for such an extensive permanent impairment rating. In fact, an examinee who has 3+ centimeters of atrophy of the thigh plus 2 to 2.9 centimeters of atrophy of the calf would qualify only for 8%, 5 plus 3, 5 plus 3. 8% whole person impairment. So I want you to think of an examinee who has 3 centimeters of atrophy of the thigh with 2 centimeters of atrophy of the calf. This is an examinee whose leg has an anatomic impairment and whose leg is certainly functionally limited, probably at least in diminished strength at both the thigh and the calf, which would affect the ankle and the foot. So would this type of examinee be expected to have some limitations to activities of daily living? Would this examinee have weakness of that lower extremity that would impact his gait? Would this examinee have some weakness in that lower extremity that involved his ability, or that impacted his ability to ascend stairs or to ascend ascents uphill? This is an examinee who's certainly going to have some limitations with activities of daily living and some functional impact of this anatomic impairment, and yet the impairment ratings do not approach that impairment rating that was provided for Mr. Cannon, who had no atrophy and had no impact on his activities of daily living that this particular type of examinee would be certain to display. Okay, and finally, let's compare that 7% whole person impairment rating to some impairment ratings associated with abnormal range of motion. So here we have table 17.9 related to the hip and table 17.10 related to the knee. And let's take a look here at some impairments that approach 7%. So here we have a whole column of impairments that qualify for 8%, which is kind of close to 7%. And imagine an examinee who has less or who has a 30-degree flexion contracture of the hip. A 30-degree flexion contracture means that the examinee during the phases of gait cannot bring his knee, cannot bring the hip less than 30 degrees of hip flexion, cannot bring the knee, the hip to 0 degrees neutral flexion, and certainly cannot extend the hip backwards into any type of an extension angle. This is an examinee who lacks the last 30 degrees and is contracted in a flexion position. So I want you to imagine, how would this type of condition impact an examinee's gait? This would create a severe impact on the examinee's ability to ambulate normally, being unable to move the hip into extension through the mid-stance and late stance phase of gait. This examinee can't even approach the mid-stance phase of gait due to flexion contracture, and for that, the guides for an actual derangement of gait provides for an 8% whole person impairment. Well, I want you to imagine an examinee who has less than 80 degrees of flexion of the knee joint, less than 80 degrees of flexion. For that, the AMA guides provide for an 8% whole person impairment rating. Now, picture an examinee who has less than 80 degrees of knee flexion. This is an examinee who's going to have trouble and difficulty getting out of deep chairs. This is going to be an examinee who, because they cannot bend their knee to even 90 degrees, cannot bring the foot underneath the body in order to propel the body properly out of the chair. This is an examinee who's going to have to initiate movement out of the chair by using his hands to push off the chair. Similarly, with less than 80 degrees of knee flexion, this is going to be an examinee who's going to have difficulty ascending stairs and even bringing their foot up to the next higher stair. So an examinee who is limited in knee flexion is going to have many impacts on their activities of daily living, including a bona fide and definite derangement of gait, particularly for getting out of deep chairs and, for example, in going upstairs. And for that, the guides provide for 8% whole person impairment. Now, what's interesting is that Mr. Cannon had normal range of motion of the hip. Okay, excuse me, we had an interruption there. So Mr. Cannon, he had normal range of motion of the hip. He had normal range of motion at the knee, and he did not have an actual disturbance of gait. And yet the qualified medical evaluator provided for a 7% whole person impairment, which, as we can see by comparison to some of these other impairments, that a 7% impairment of the lower extremity in these other impairments represents significant limitations in activities of daily living. And I've given you 3 examples of different impairments, all of which affect gait, and yet Mr. Cannon had no actual disturbance of gait. So let's take a look at the gait derangement table to see if we can understand how this permanent impairment rating came to be upheld by the Workers' Compensation Appeals Board. Okay, so let's take a look now at Table 17.5. This is the gait derangement table in Chapter 17. Okay, so here's our whole person impairment ratings in this column, and we see that they range from 7 to 15% whole person impairment. Now, let's just take a look at Category C and Category D. Both of these gait derangements require an assistive device by the examinee. So with Category C, you can expect this examinee to present to the evaluation with a cane or a crutch that they require for distance walking, but usually not at home or in the workplace. So this examinee can be placed into this category of gait derangement simply by observation. If you're convinced that the examinee requires the use of a cane or they require the use of a crutch for distance walking, you can place them in this impairment category. Similarly, with Category D, this examinee requires also an assistive device, in this case the use of a short leg brace, an ankle or foot orthosis, for example. So this examinee will present to the evaluation with an assistive device in place. And if you're convinced that this is a medically necessary assistive device and that the examinee truly requires this, then you can place the examinee in this category. So in that sense, these 2 categories of gait derangement impairments do not require an observation of gait, and that makes them distinct and different from the first 2 categories, which actually require an observation of the examinee's gait. So for example, in Category A, you will observe the examinee to have an antalgic limp with a shortened stance phase of gait. So this requires that you actually perform a gait evaluation on the examinee, that you take the examinee outside of the examination room, either to a long hallway or a long parking lot, and actually observe them to walk. Because how can you diagnose an antalgic limp without actually observing the examinee to have a shortened stance phase on the involved lower extremity? You cannot. You're required to actually observe this. Similarly, if you observe the examinee to have a positive Trendelenburg gait, then you can place them in Category B. But again, this requires that you actually observe the examinee to have a Trendelenburg gait. So in providing for an analogy to gait derangement, the agreed medical evaluator provided for 7% whole person impairment by analogy to an antalgic limp with shortened stance phase, and here's the second requirement required to be able to provide for a Category A impairment, Category A gait derangement impairment, the examinee has to now have some objective findings that support the gait derangement. And in this case, it requires moderate to advanced arthritic changes of one of the lower extremity joints involved with gait. So that could involve either the hip, the knee, or the ankle. So here, the gait derangement, the gait impairment involves a subjective component, which is the antalgic limp with shortened stance phase. That's the subjective component. And it also requires an objective finding in the form of moderate to advanced arthritic changes of the ankle, knee, or hip. Well, in the Cannon case, we have no evidence, at least from reviewing the case. We don't actually have the agreed medical evaluator's report. We simply have the case that we can review. We have no evidence, because there's no mention in the case, that the agreed medical evaluator did an actual observation of Cannon's gait. We don't know that he took the examinee outside to a long hallway or a parking lot and actually observed Mr. Cannon to walk back and forth several times to observe an antalgic limp with a shortened stance phase. So we don't know that he did a gait evaluation or not. Similarly, there is no mention that Mr. Cannon actually had an antalgic limp, or that he actually had a shortened stance phase. And Mr. Cannon, at 37 years of age, did not have documented arthritic changes of either the ankle, the knee, the hip, or the foot. So it's so interesting that the agreed medical evaluator provided for a huge permanent impairment, which would otherwise be very, very difficult to qualify. Very difficult to have both of these subjective and objective findings present in the same examinee. A bona fide antalgic limp with a shortened stance phase that's supported by objective imaging evidence of moderate to advanced arthritic changes of the involved articulation. Mr. Cannon had neither of those, and yet the agreed medical evaluator opined that he qualified for a huge permanent impairment rating of 7%. Well, let's review some of the history and the outcome of this case, and then I'll provide for you the operative principle that you can employ in your upcoming evaluations. Okay, so let's read from the case. So the date of injury was October 2008. Mr. Cannon injured his left foot and heel while working as a police officer for the city of Sacramento. He was diagnosed with plantar fasciitis. He was given physical therapy, a cortisone injection, and an orthotic device. His primary treating physician found him permanent and stationary in January 2010, so that's more than a year later. That's 14 months later, with no impairment of his activities of daily living and capable of performing his usual occupation. Now, that sounds about like the typical outcome for plantar fasciitis. It's usually a self-limited condition that recovers to pre-injury condition, and on we go with our lives as before. Well, shortly thereafter, an agreed medical evaluator, Dr. William Ramsey, agreed that Cannon was permanent and stationary and that there was no impairment, but he recommended that Mr. Cannon be precluded from such things as prolonged running, because apparently Cannon said that with prolonged running, that was when he most was impacted by this plantar fasciitis condition. Well, in February 2011, at the request now of Cannon's attorney, this is the applicant attorney, Dr. Ramsey issued a supplemental report, quote, to comment on Mr. Cannon's impairment status using Almarez Guzman 2 issues. And you yourself might find yourself receiving such similar types of letters from applicant attorneys asking for an alternative impairment rating under Almarez and Guzman. Well, in response to this, Dr. Ramsey explained that at the time of his original report in October, he was, quote, unable to offer any impairment from a strict interpretation of the AMA guides because other than some tenderness, you can imagine that there might be some tenderness to deep palpation pressure over the calcaneal tubercle or under the origin of the plantar fascia. there were no objective abnormalities that were identifiable. In other words, range of motion was normal, there was no ankylosis, no peripheral nerve involvement, and none of the impairments that are described in Table 17-1. But now, under a consideration of Almarez and Guzman, Dr. Ramsey determined that it was acceptable to characterize Cannon's residual condition using a gait derangement abnormality by analogy, using Almarez Guzman as a basis. Noting that Cannon's problem was relatively mild, with the left heel causing weight-bearing problems, and the likelihood that the condition would be aggravated appreciably by running activity other than a short-term basis. In other words, by prolonged running. However often Mr. Cannon was involved with that. Well, on these bases, Dr. Ramsey recommended characterizing Cannon by reference to Table 17-5 as having a limp, an antalgic limp, despite the absence of any arthritic changes about adjacent joints, equivalent to 7% whole person impairment. Okay, so this is interesting. He characterized Cannon as having a limp when Mr. Cannon did not have a limp, and Mr. Cannon did not have the subjective component of the category A gait derangement, nor did he have the objective component of the imaging findings of moderate to advanced arthritic changes. And yet, even in the absence of those findings, he opined that the examinee qualified for 7 whole person impairment for a condition that qualified for 0% whole person impairment under the strict application of the AMA guides. Well, of course, upon seeing a 0% whole person impairment rating escalate and balloon up to a 7% whole person impairment rating, the defense attorney had some concern. So shortly thereafter, in June 2011, at the request of the defense attorney, Dr. Ramsey issued a second supplemental report to further discuss the basis for his recommending some impairment due to Mr. Cannon's residual heel complaints. In this report, Dr. Ramsey noted that, quote, heel pain, or for that matter, other aspects of pain that do not have any accompanying objective measurement abnormalities, do not rate anything in the AMA guides, whether or not these problems interfere with one's activities. Thus, a strict interpretation of the guides does not always appropriately characterize an injured worker's problems. Now, this is interesting because you are going to have examinees who do not have accompanying objective measurement abnormalities. In other words, they have a normal physical examination. Even so, they may have subjective complaints of pain. Subjective complaints of pain in the absence of, or I should say in the presence of a normal physical examination, these types of problems typically do not rate or do not qualify for impairment under the AMA guides. But here Dr. Ramsey provides an opportunity to provide for permanent impairment rating for these examinees who have an otherwise normal physical examination. Dr. Ramsey explained because Cannon's heel pain interferes with weight-bearing activities, particularly running. This is fascinating. His heel pain interferes with running, which he characterized as a weight-bearing activity. He thought that by analogy, and I'm not sure quite what the analogy is, he thought that by analogy, it would be similar to an individual with a limp and arthritis, resulting in the 7% impairment recommended. Now, I'm not exactly clear on how analogy is similar to an individual with a limp and arthritis, except that an individual with limp and arthritis has problems with weight-bearing activities, similar to the weight-bearing activity involved with running. So the analogy is not to any particular condition. The analogy is to an impact on activities of daily living. So in this case, the condition A, which is Mr. Cannon's heel pain, the condition is plantar fasciitis. Plantar fasciitis interferes with weight-bearing activities, where a person who has arthritis in the ankle, knee, or hip also has problems with weight-bearing activities, which would cause them to limp. So in this case, the analogy is not to an analogous condition, but to an analogous limitation with activities of daily living. It's not in any way related to analogous conditions because Mr. Cannon did not actually have a gait disturbance. Mr. Cannon did not actually have moderate to advanced arthritic changes. Okay, it's quite fascinating as to how this analogy is actually constructed. Well, the case was tried in October 2011. In a trial brief, the city argued that a rating by analogy under Almarez and Guzman would be proper only if the case could be characterized as complex or extraordinary, which Cannon's injury could not be. And the workers' compensation judge agreed on this, finding that Cannon had no permanent disability because his medical condition was not complex or extraordinary, and therefore did not warrant a strict departure or a departure from the strict application of the AMA guides. So when you see your impairment go from 0 to 7 to 0, of course the applicant is going to have something to say about it. And sure enough, Mr. Cannon petitioned for reconsideration, arguing that a case does not have to be complex or extraordinary to be rated by analogy under Almarez and Guzman. The board granted reconsideration and, agreeing with Cannon, they rescinded the workers' compensation judge's findings and award, which was for 0% permanent disability, and returned the matter to him for a new permanent disability rating based on Dr. Ramsey's findings. With one member dissenting, the Workers' Compensation Appeals Board explained that the language cited by the judge to limit a rating by analogy only to cases with complex or extraordinary medical conditions does not support his interpretation. Rather, that interpretation, rather than further restrict a physician's expertise, this language should be read to reflect the ability of a physician to rate an impairment by analogy within the four corners of the AMA guides, where a strict application of the guides does not accurately reflect the impairment being assessed. And you're going to find this in many, many conditions that are characterized by subjective complaints only. Doctors, you're going to find that in some cases, a strict application of the AMA guides does not accurately reflect the impairment being assessed. The board noted that Cannon's condition, which is plantar fasciitis, does not have a standard rating under the AMA guides, with no specifically applicable chapter, table, or method provided in the guides, and therefore this condition can only be rated by analogy to other impairments and/or, and here's the crux of the matter, and/or by analysis of the injury's impact on activities of daily living. And the agreed medical evaluator described the impact of Mr. Cannon's plantar fasciitis on his weight-bearing activities of daily living. So fascinating construction of the analogy. The board concluded that Dr. Ramsey had provided by analogy an accurate assessment of Mr. Cannon's medical condition that meets the requirement of Almarez and Guzman for a condition that is not covered by the AMA guides. And so let's review some of the operative principles and take-home messages from the Cannon case. So in the Cannon case, the workers' compensation judge initially opined for 0% whole person impairment, but upon appeal, the appeals board, and I think it was a 2 out of 3 decision, the appeals board upheld the 7% impairment rating. And here is the principle that you can apply to your very next evaluation. So it tells us that the AMA guides to the evaluation of permanent impairment cannot rate syndromes that are poorly understood and are manifested only by subjective symptoms, such as plantar fasciitis, and such as many of the conditions that your examinees are presenting with. They all present, of course, with subjective symptoms, but in some cases, these examinees present with normal physical examinations, and the Cannon case provides a precedent for which you can provide for permanent impairment even in the context of a normal physical examination. And in order to accommodate these complex or extraordinary cases, complex and extraordinary, and we're going to define complex and extraordinary in a minute, the AMA guides call for the physician's exercise of clinical judgment to assess the impairment most accurately. So here you're allowed to use your clinical judgment and depart from the typical table, the typical chapter, or the typical method described in the AMA guides. Now the term complex or extraordinary, as used in case law here, does not refer to the medical condition being evaluated. And sometimes you'll see defense attorneys object on the basis that the medical condition is not complex or that the medical condition is not extraordinary. But as it's used here in case law, this term describes syndromes simply that are poorly understood and are manifested only by subjective symptoms, which the AMA guides do not and cannot rate. So cases that are complex or extraordinary are simply cases that are not described in the AMA guides or not rated by the AMA guides, particularly those cases that involved subjective symptoms and a normal physical examination. And the conclusion of the Cannon case is largely based on premises espoused by the Almarez and Guzman cases. And that has to do with Labor Code Section 4660 in describing the permanent impairment rating. So the Cannon case tells us, and this is the instructive principle, it tells us that although the whole person impairment component of a scheduled rating must be founded in the AMA guides, must be founded within the four corners of the AMA guides, a physician is not inescapably locked into any specific paradigm for evaluating whole person impairment under the guides. Section 4660 tells us that the whole person impairment component of a scheduled rating is to be rooted in, quote, the descriptions and measurements of physical impairments and the corresponding percentages of impairments published in the AMA guides. So therefore, Section 4660B does not mandate that the impairment for any particular condition must be assessed in any particular way under the guides. And in the Cannon case, Dr. Ramsey used his clinical judgment, and in my opinion, he used his imagination. And we are only limited by our imagination in providing for impairments within the four corners of the AMA guides. And they tell us that while the AMA guides often sets forth an analytic framework and methods for a physician in assessing whole person impairment, the guides do not relegate a physician to the role of taking a few objective measurements and then simply mechanically and uncritically assigning a whole person impairment that is based on a rigid and standardized protocol and that is devoid of any clinical judgment. Instead, the AMA guides expressly contemplates that a physician will use his or her judgment, experience, training, and skill in assessing whole person impairment. So there you have it, doctors. The Cannon case sets the precedent, piggybacked on the Almarez and Guzman line of cases, for providing for permanent impairment ratings by analogy to any condition, any chart, any chapter, any table, any method. So there you have it, doctors. This is a fascinating case, the Cannon case. And the Cannon case sets several important precedents for us as qualified medical evaluators. So to review the key points of this case, Cannon presented to the physical examination with some minimal subjective complaints, and he had a normal physical examination. So how many of your examinees are similar to this? They present with subjective complaints, typically pain, 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 and subjective limitations to activities of daily living, but they have a normal physical examination. In the Cannon case, the agreed medical evaluator described some limitations with weight bearing, especially prolonged running. But the agreed medical evaluator never took Mr. Cannon out to a track or to a field and observed him to run. He simply took it upon the examinee's testimony that he had some subjective limitations with running. So the complaints were subjective only. The limitations to activities of daily living were subjective only. This describes many of the examinees that you're going to see, and so this is where you can employ the principles of the Cannon case. He opined that the type of condition is not rated in the AMA guides. And how many times do we see examinees that have conditions that we could diagnose? If they were in our clinical practice, we would give them a diagnosis. We would give them an ICD-10 diagnosis that's not described in the AMA guides. But the diagnosis that we provide for the examinee may have some similar limitations to activities of daily living as other conditions that are described in the AMA guides, and that's wherein you can create an analogy. In the Cannon case, the doctor provided an analogy to gait derangement, and this is fascinating. When there was no actual derangement of gait, there was no limp, no antalgic limp, there was no advanced to moderate to advanced arthritic changes, there was no need for assistive device, and no physical actual examination of Mr. Cannon's gait. So to me, that's absolutely fascinating that the agreed medical evaluator could provide for a huge 7% whole person impairment, similar to other conditions in the AMA guides that do involve actual derangement of gait, that do involve a limp, that do involve arthritis, that do involve a need for assistive device, and yet Mr. Cannon, by analogy to similar limitations and activities of daily living, was able to qualify for similar impairment, even in the absence of the actual impairment. So, doctors, I hope this helps expand your imagination to some of the different applications of the AMA guides that you can employ, and combined with the Almarez and Guzman decisions, and even combined with what we talked about involving the kite decision in our last case, these cases provide for you tremendous opportunities to provide for permanent impairment ratings for examinees who otherwise would not qualify for any permanent impairment under the AMA guides or under a strict interpretation of the AMA guides. So really, you're limited only by your imagination, and it might be a good exercise for you to review the AMA guides and the limitations to activities of daily living described by some of the conditions in the AMA guides to serve as a beginning point or a beginning place to consider how your examinee's limitations to activities of daily living can be analogized to other conditions in the AMA guides that have similar limitations with activities of daily living. Okay, doctors, so I hope this helps you. In our next session, we're going to talk about the Melgoza-Garibay case, which, if you think the kite and Cannon cases allow liberal construction and liberal application of principles in favor of the examinee, wait until you see what I have to share with you regarding the Melgoza-Garibay case. So look forward to being with you on our very next session. And for now, it's my pleasure to have been with you here today. I hope you learned a lot from today's discussion. And I'm wishing you best of success in your career as a qualified medical evaluator.